Can you guys hear me now? Leena, Beth? Okay, that's why. It was muted on my computer. Okay, good. Got it. Okay, I was trying to. Okay, should I get started then?
Yes.
Okay, great. Okay. Hello. Good afternoon. It's almost afternoon now. Welcome to our clinical conversations. So I'm Nancy Byatt. I'm the medical director of MCPAP for Moms, and this is one of our quarterly webinars. Today's topic is updates on perinatal substance use disorders, cannabis, and emerging substances, and other emerging trends in treatment. And I'm pleased today for our speaker, Dr. Leena Mittal, who I'll introduce more in a few minutes. So for just a few housekeeping things before I do that, the session will be recorded and available on the MCPAP for Moms website at www.mcpapformoms.org. A copy of the PowerPoint is also going to be available on the Tools and Resources page under PowerPoint presentations. And at certain points, Dr. Mittal will stop for questions during the presentation, and there'll also be time for questions at the end. If you do have a question or comment, please type into the question box during the presentation, and we will read your question out loud, or we will unmute your line to enable you to ask your question. You will also receive a very brief survey following the presentation. Please fill those out. We really appreciate your feedback. It helps us improve our future presentation. We also welcome ideas for topics for future presentation in the feedback. So I'm pleased to introduce Leena Mittal. She is the Associate Medical Director of MCPAP for Moms, and she has been really the driver behind and the leader behind all of our substance use initiatives. She is an instructor at Harvard Medical School and the director of the Division of Women's Mental Health of Brigham and Women's. And she specializes in the treatment of perinatal mental health and substance use conditions. She graduated from the Harvard Longward Psychiatry Residency Program, and she also completed a fellowship in consultation liaison psychiatry at Brigham and Women's. She's board certified in psychiatry, consultation liaison psychiatry, and also addiction medicine. And her clinical and academic focus includes collaborative care for complex perinatal patients with mental health and substance use needs, and also integrated treatment for pregnant and postpartum women with opioid use disorder embedded within perinatal care settings. She's also worked on programming addressing maternal mental health within the NICU at Brigham and Women's. Dr. Mittal is a committed educator. She teaches medical students and residents and fellows, and she also serves as the program director at the Women's Mental Health Fellowship at Brigham. So I've worked with Leena for a long time. We're very excited to have her present today. And I've heard a lot of people talk about substance use disorders, and Leena really does a wonderful job. So I'm excited to present her. Again, if you have a question, please use the question function to ask questions, or click the raise hand button, and we'll unmute your line. Thank you, and Leena, please start.
Thank you so much, Nancy, and thank you for the kind words, and thank you all for attending. My goal is really to kind of talk in broad brushstrokes about sort of what are some of the basics around assessing and managing substance use disorders during the perinatal period, meaning during pregnancy and postpartum, but then also to kind of use the sort of 101, the basics, to really think about some of the new things, the new trends that we're seeing in our state and in the field in general for perinatal substance use as we understand it now, because it's really an evolving field, and one where there is a lot of active work going on, much of which is going on locally. Just by way of formality, I have done a little bit of consulting for Sage Therapeutics, and then half of my salary is paid for by our Department of Mental Health for MCPAP for Moms, but otherwise I have nothing else to disclose. And I always think it's really important to underscore that I think we all, as anybody who interfaces with women who are pregnant or postpartum, I think we often start from a general understanding that substance use during pregnancy carries risk. But I think it's always really helpful to be explicit and to think explicitly about the different layers of risk that are encountered. And the risks are to the woman herself, to her fetus in pregnancy, as well as to her family, the growing family, and the child who may be part of her family, children who are maybe already part of her family, partners, but also the child who may result from the pregnancy. So any substance use during pregnancy exposes the pregnancy to teratogens or to substances or things that can cause birth defects, as well as during the course of a substance use disorder, often women are not necessarily taking in the things that can help aid the health of a pregnancy, so good nutrition, hydration, those kinds of things. Substance use during pregnancy also creates often a shortened window. Pregnancy can often be unexpected, and so the recognition of pregnancy may be delayed, and so engagement in prenatal care and substance use disorder treatment can be delayed as a result. A lot of people who have substance use disorders have to often engage in various forms of human trafficking that may include exposure to violence, coercive or forced sexual encounters, and other types of trauma, and that's really, really particularly common for women, and so it's important to be thoughtful about that and mindful of the kind of IPV, intimate partner violence and interpersonal violence that may be part of a woman's life who's struggling with substance use disorder. Substances themselves can alter the function of the placenta in pregnancy and cause difficulties with labor management, both related to intoxication and withdrawal. Withdrawal from substances themselves can be really risky. Women who have substance use disorders also are at risk for overdose, which can, in catastrophic cases, result in death, making substance use, and in particular opioid use disorder, an important preventable cause of maternal and infant mortality, and so something that we should be really tuning into in terms of thinking about how we can decrease these rates. And then also substance use, depending on the route of use of the substance, can increase risk for infectious disease like HIV and hepatitis C, as well as also infection related to depressed immune system and other types of infection. And so just to kind of underscore the importance of looking at the contribution of substance use disorders to maternal mortality, it's important to, these are data from one of the first studies to show that opioid use disorder is really, in particular, but also just substances in general, are really a cause of the growing maternal mortality story that I think we're all increasingly aware of. So this is a study out of Colorado looking at the causes of maternal death from 2004 to 2012. So in that time, in that window, there were approximately 211 total maternal deaths, 90% of which took place in the postpartum period. So when looked at in terms of cause of death or associated causes of death, the numbers classified as related to accidental overdose or suicide alone were greater than the number of deaths accounted for by postpartum hemorrhage and preeclampsia combined. And of those, the majority had at least some component of the contribution of substances, included opioids, 48% in fact. And these numbers are paralleled here in Massachusetts. So pregnancy-associated deaths related to substance use, these are data from our own DPH, are on the rise. If the data were to go out more recently, I think we're starting to see a slight leveling off of the rates of death, but nonetheless, this is staggering and an important thing that we need to be all paying attention to, and parallels the opioid epidemic and the rates of death outside of pregnancy as well, but nonetheless. But I think the sort of hopeful piece here is that medication treatment for opioid use disorder the data clearly show can actually decrease maternal mortality. These data show that, I don't know if you'll be able to see my cursor, but the bottom part of this graph shows that the rates of death broken down by time in pregnancy and months postpartum. The gray bars in the bottom half show overdose events for women who were not on pharmacotherapy, and in these data, specifically, it's methadone and buprenorphine, or Suboxone or Subutex. So the gray bars are those who had overdose events not on pharmacotherapy versus those who were on the rates of overdose for those on pharmacotherapy. And so as you can see, there's a really distinct impact of treatment on the rates of maternal mortality. And so this is, while a sobering message and one that really underscores how significant this problem is, it's also one, I think, of hope, because I feel like it gives us some sense that we have an opportunity to move the needle here. And the other piece of this in terms of thinking about opportunity is I think in general pregnancy itself is a window of opportunity for women. Most women are highly motivated during pregnancy to stop using substances and to start engaging in other health-related behaviors. And so what these data are sort of demonstrate are from the National Survey on Drug Use and Health, that when asked about past month drug use in women of reproductive age, those who were not pregnant had significantly higher rates of use for all types of substances, and those who were pregnant as compared to those who were pregnant currently. And so one of the things that the 2 points here, I think, are that the majority of women are highly motivated to stop using substances and are often able to stop using substances during pregnancy, making the sort of the motivation that's inherent in pregnancy and the hopefulness really, really important to leverage. But there are also a subset of women who are not able to stop during that time, and those women, I would posit, have a more severe sort of subset of the substance use disorder, that it is a sign of severity if someone, despite the high motivation inherent in pregnancy, is not able to stop. And substance use during pregnancy really does present us with a significant amount of opportunity, but also challenges. So those women who are contending to use, they do have a very refractory, difficult to treat illness. There are legal issues that we face for treatment of women who are pregnant and in the early parenting phase that are different than as providers than those who, than when we're treating people who are not parenting or who are not pregnant, in particular around reporting for child welfare and so on. Often the time during which we have to work with these women is sort of contracted. Women may present later because the pregnancy was unexpected and unplanned and so discovered later into pregnancy, or she may be delayed in presenting due to shame, stigma, fear of judgment, fear of reproach or punitive treatment. And then the time to delivery, the time between presenting and the time of delivery becomes relatively shorter depending on the time at which she presents. And so that gives us less time to engage in all of the different multidisciplinary care that a woman may benefit from. And women really do face a lot of inherent shame and stigma, and we as providers are often consciously or unconsciously part of the bias that they face, and we have our own reactions, and so that can be really challenging for women in terms of engaging with care. And then also, women with substance use disorders are faced with a fair amount of challenge in terms of reproductive life planning in general, feeling they have access to adequate counseling around family planning and the availability of family planning services, and having the opportunity to have conversations about how to engage in family planning and plan pregnancies if they want to become pregnant in a healthful way or avoid pregnancy otherwise. And substance use, active substance use, can have significant endocrinologic impact such that it can be challenging to plan for pregnancy and to have regular cycles. And so that's another sort of inherent challenge in this population, both in terms of prior to pregnancy and the preconception phase, as well as postpartum. And then it's particularly hard for women and providers to feel there's access to adequate subspecialized care that is tuned into the unique needs of this population. And women with substance use disorders can really come to the attention of providers really throughout the pregnancy and postpartum period. So women who may be stable with substance use disorder, may be in remission, and may present preconception saying they'd like to plan a pregnancy. They may present at the beginning of prenatal care disclosing substance use disorder. They may not present until a screening questionnaire is administered at some point during pregnancy about substance use. Sometimes women present later in pregnancy because there have been behaviors that have been concerning, and providers eventually become concerned, wonder about whether there may be substance use disorder, and there may be unexpected findings on a toxicologic test or on fetal testing, or otherwise patients, women, may present in the postpartum period because there may be withdrawal noted in the neonate, and that might be the first time that the treatment team is aware that there had been maternal substance use. So it's really important to be tuned into the fact that we may not always know, and this can kind of come up at any point in caring for a woman and her family. Toxicologic screens are part of the assessment for substance use, and that may be one of the ways that we detect. But one of the things that we're really trying to do, and I think is really an important effort throughout the field and throughout our state in particular, is really engaging in universal screening for substance use. A number of organizations recommend universal screening for substance use at the beginning of pregnancy and then at various time points throughout pregnancy as well. We recommend using the TAPS tool, which is based from out of the NIDA quick screen. And I'll show you at the end how you can find copies of this screen and access more information about how to interpret and implement screening. Once screening is done, though, it's really important to be thinking about how do you manage. And so we have some tools, and again, I'll share with you a little bit how you can access them, about how to kind of think about how you engage in treatment and engage in assessing first what a woman may need, really kind of by assessing what's going on currently, and then using the information that you get to stratify her risk in terms of severity. But once you're sort of faced with the idea of potentially treating a substance use disorder or referring for treatment, it's always about balancing the risks of untreated symptoms alongside the risks of treatment. And I think as we've sort of been discussing up until now, the risks of untreated substance use disorder are many and are significant. And so in thinking about the risk, one of the important things to be discussing from the very, very beginning of engaging with a woman who is either currently parenting or will be hoping to parent after delivery is the importance of kind of being aware of the risks for engaging child welfare services or social services. In our state, we call them DCF, the Department of Children and Families, and there should be a conversation about what is called the plan of safe care, because pregnant and parenting women with substance use disorder really benefit from having a collaborative and engaged team of providers. And the more that collaboration can be outlined early, we can take sort of a strengths-based view of what's going on and do a needs assessment as early as possible and try to enlist services. And so the plan of safe care is really a tool. It's a tool that's being sort of rolled out in different ways in different states. In our state, it's called the Plan of Safe Care. You can find templates for it, suggested templates for it. It's really a document that just helps to kind of highlight what the services a woman is engaged in, and helps to create a mechanism for identifying needs that could be better addressed, and then suggestions for how to address it. And it's something that is a way of kind of organizing information that the woman can hold, so at the time that a DCF report is made, she can demonstrate all of the things that she's engaged in. So that's kind of just by way of sort of a baseline, just thinking a little bit about what we kind of already know about substance use and its assessment and management in pregnancy. I'm going to shift a little bit to talking about opioids in specific, unless there are some specific questions. And this might be a time to pause and take a couple of questions if there are any. Okay. So opioid use, given that we've sort of talked about the significant and catastrophic outcomes from the escalation of opioid use in our country and in particular in our state, opioids, it's just important to remember that opioids themselves are not directly teratogenic, meaning the opioids that someone may be taking for either for prescribed opioids that are for suggested use around pain management, or licit or illicit use, non-medical use of opioids, is not going to result in a risk for things like structural abnormalities or malformations, but really the disorder involves increases in higher levels and then sudden drops in levels, and kind of a cycle of intoxication and with potentially withdrawal that really puts a pregnancy at risk for a number of complications, including intrauterine fetal demise, growth restriction, placental dysfunction. There are some data suggesting reduced cognitive function in children who are exposed to opioid use disorder. And the rates of opioid use are increasing specifically in the United States, in particular, as well as in Massachusetts. And so we're seeing increased prevalence of just opioid-exposed pregnancy. Opioid use disorder, when the use of opioids is outside of a prescribed use or is in excess of a prescribed use or is problematic from a point of view of functioning would then be called an opioid use disorder. And while there are no defined FDA treatments, the mainstays of treatment for quite a long time now have been methadone, meaning methadone maintenance treatment in an outpatient federally licensed facility that people would present to and get daily dosed or dosed at some sort of regular interval, or they might have take-homes, and buprenorphine, which for the past several years, we've really focused on buprenorphine in single formulation. The brand name would be Subutex, otherwise buprenorphine generically. And so increasingly now, we are understanding that outside of pregnancy, we often are using buprenorphine in combination with naloxone, and that the brand name for that would be Suboxone. And it's available in combination partly as a deterrence to misuse and partly as a convention. This is the way it's most often available. And so in pregnancy, there was this notion that we would use simply the single formulation of buprenorphine without the naloxone in it to limit the amount of exposure for the pregnancy to any additional agents or medications. However, as it's become clear, anecdotally, we're seeing that it's harder to fill prescriptions for single formulation buprenorphine. Women are reporting that pharmacies are not necessarily keeping it in stock, and it carries a higher street value, so people can feel at risk. They can feel like it's challenging to keep their medications safe, and not being able to adequately fill their prescriptions adds an additional amount of a layer of stress that was at some level at odds, counter-therapeutic to maintaining recovery. And so it's been kind of examined over time that it may be the better part of valor to provide the combination formulation, the buprenorphine with naloxone in the context of pregnancy. And so this has become an emerging trend in treatment where we're increasingly seeing treatment programs providing the combination rather than switching people to the single formulation of buprenorphine. There is some emerging data suggesting that pregnancy outcomes are similar, and naloxone itself is not actually absorbed at any significant clinically important rate when used appropriately sublingually. And so this is something that has been an increasing practice, and you may see happening for those women who you may interface with over time on buprenorphine. And another part of treatment that's has emerging data is the use of naltrexone. Naltrexone is available orally as well as in a monthly IM depot medication. The brand name for that would be Vivitrol, and the oral formulation would either be available generically or as Revia is the brand name. And naltrexone is something that the data suggests not quite as effective as methadone and buprenorphine for achieving extended recovery, but for many patients on an individual basis, if they find that they're doing well on it, or if they've already received a depot injection earlier but prior to being aware of pregnancy, may already be on naltrexone. And so there's emerging data suggesting, again, there's no differences in pregnancy outcome in these relatively small studies for naltrexone. And we'll talk a little bit more about that as that goes along, but I just want to highlight a few sort of shifts in the way we're approaching treatment. Now, buprenorphine itself, one of the things that, while it's emerged as a real mainstay of treatment in pregnancy and outside of pregnancy, of course, there are some challenges to starting buprenorphine. And often, one of the challenges is that the person who's starting will need to be in mild to moderate opioid withdrawal before they can start the medication. And that can sometimes be really hard for patients for women who may find it hard not to use for a period of time prior to and emerge into a state of withdrawal. That may be very, very challenging. And if they're not in a situation where they can come to an inpatient setting and have this transition take place in this way, there are approaches that it's called microdosing, where there's a very, very small amounts of buprenorphine are given even prior to the emergence of withdrawal. And this is something that we do not have any data on for its use in pregnancy, but this is something that is emerging as a way to initiate treatment with buprenorphine early and keep somebody engaged early on rather than expecting them to wait until they're in sort of full withdrawal. And so this is something that patients may mention in the course of their presenting for treatment, or let you know this is something that's happened in their history. And so it's just useful to know that essentially what happens is small amounts of buprenorphine are administered while the person is continuing to use their full agonist opioids, and then the full agonist opioids are gradually decreased while the doses of buprenorphine are gradually increased to a full daily dose. Additionally, buprenorphine is now available in a number of formulations, and one formulation that we're seeing used more often clinically is the depot monthly injection of buprenorphine. That is an IM injection that takes place in the abdomen, and so it's not something that we're using in pregnancy at this point. There has been no study of this depot long-acting buprenorphine injection in pregnancy, but if somebody becomes pregnant while on this medication, it's important to understand how it works. It's a monthly medication. It's something that only contains buprenorphine. There's no naloxone or any other agent in the medication, and it's just something that we're increasingly see used. Payers are increasingly covering this treatment. It's especially useful for people who have a hard time maintaining a daily medication, but have responded well to buprenorphine in the past. And so it's just something to also be aware of as something that it's sort of, more to be seen as this emerges. We've talked a little bit about naltrexone already. If somebody's already stable on naltrexone or has demonstrated that they've not been able to achieve sobriety or decrease their use while on an agonist treatment like methadone or a partial agonist treatment like buprenorphine, naltrexone may be a reasonable option. There is emerging data for its use in pregnancy. Our colleagues at Boston Medical Center are actively studying naltrexone in pregnancy now. I think there's going to be a lot more to be seen as that study goes on, and eventually they're able to publish all of their data. But I think it's an active area of study, and I think we should also be aware that naltrexone may become a third tool in our armamentarium. Now, this is not necessarily an emerging or a new piece of information, but one that we should just all be aware of, that naloxone should be prescribed to anybody who may be at risk for opioid overdose. And so that includes anybody taking opioids, anybody with a history of prior overdose, anybody with a family member who might be on opioids, or who may be living with someone who is at risk for overdose. So really what I'm sort of advocating here is very, very wide prescription of naloxone. And many places, including many townships, many pharmacies are giving naloxone out even without a prescription, or it's free even with a prescription. They're covering the cost of the medication. As we talked about earlier, suicide and overdose are leading causes of maternal mortality, and even just the medications used for the treatment of opioid use disorder can put other people in the home at risk for overdose, and so it's important to have naloxone available at any time that there may be a risk for overdose. Again, I'll just pause here and see if there are any questions, and if not, I'll just kind of move on. Whenever we're talking about opioid use, we really do need to talk about opioid withdrawal in the neonatal population for those that are exposed in utero to opioids. We have talked for many years about neonatal abstinence syndrome, and so we're sort of shifting that nomenclature to neonatal opioid withdrawal syndrome. The description is more specific. The term is more descriptive in general, and then also it avoids confounding with neonatal adaptation syndrome, which is a syndrome of adjustment and not withdrawal that's associated with maternal use of other psychotropic medications like antidepressants. What is really encouraging and exciting about the field of neonatal opioid withdrawal, which is something that's really kind of happening in our state actively, is the rolling out of a really evidence-based and effective approach to management of neonatal opioid withdrawal syndrome, and that's the Eat, Sleep, Console approach. For years and years and years, for decades, we've talked about that non-pharmacologic treatment is first line for neonatal opioid withdrawal, and yet most centers were really centering their treatment of these babies around medication and using opioid replacement or other medications for management. And increasing data have shown that if we stand by that non-pharmacologic treatment with increased support of the maternal infant or the caregiver infant dyad, is implemented in this way, that you can decrease time in the hospital and enhance the mother-infant relationship, decrease the need for medication. Our colleagues also at Boston Medical Center have published, as well as colleagues at Yale, about this particular approach called Eat, Sleep, Console, which really prioritizes the baby's ability to feed, the baby's ability to rest and sleep, and soothe him or herself or console himself as the primary outcomes. And so all efforts to be made with as much non-pharmacologic soothing as possible towards those ends can significantly decrease all of these measures, including time in the hospital, time away from their caregiver outside of a hospital setting, decrease entirely the need for medication. And that also enhances the breastfeeding relationship, which is also really important as well, or highlights the breastfeeding relationship, which is really important when possible.
So, Leena, before you go,
yeah, sorry.
We had a question that came in. What is the mechanism of action for naloxone ongoing therapy in SUD?
For naltrexone? Sorry, I should have mentioned this more explicitly. So naltrexone, well, methadone is a full agonist at the mu-opioid receptor, and so stimulates the receptors in the opioid system in the same way that substances that are often abused, like heroin or fentanyl or oxycodone or prescription for medications do that. Methadone is much more similar in activity to those medications. Buprenorphine is sort of in the middle. It's a partial agonist. It partially stimulates that receptor system and achieves some of the same symptoms and some of the same effects, but most importantly can avoid withdrawal symptoms. Naltrexone, on the other hand, is an antagonist, meaning it blocks those receptors and it blocks the effects of opioids. And I'm sorry I didn't make that distinction earlier on. And the reason we use naltrexone is really almost to avoid stimulating or creating any potential possibility of the psychoactive symptoms or psychoactive effects of opioids. So it would make someone not be able to achieve the euphoria, the intoxication of opioids. And so that's why it's thought of as a treatment. Okay, so I'm gonna, if there aren't other questions, I'll move on to just talking a little bit about alcohol use in pregnancy. So there really hasn't been a lot in the way of advancing much better understanding about alcohol use in pregnancy, other than we do know that alcohol use, heavy alcohol use, and the defining of heavy is still not entirely what exactly is the amount that defines too much use in alcohol in pregnancy, is associated with neurodevelopmental conditions, what we used to call fetal alcohol syndrome. What's particularly notable now, though, is that the little bit of prevalence data that we do have about use of alcohol in pregnancy suggests that the use of alcohol is actually rising despite significant public health efforts over the past decade or more to try to decrease alcohol use. And so in the most recent prevalence data looking at women's use from the years 2015 to 2017, those asked about any binge pattern use in the prior 30 days. In women who are pregnant, 4% endorsed binge pattern use in the prior 30 days during pregnancy, and 12% of women suggested or disclosed any alcohol use. And that's a significant rise from earlier years where we're seeing much lower rates. Also, in parallel to this, there was one study that really looked at a few localities and noticed that, and within school-aged population, looking at first graders, the prevalence of fetal alcohol syndrome signs is much more prevalent. Previously, we were under the assumption that it was about 10 in 1,000 children had some signs of fetal alcohol exposure, whether that be in structural facies or discriminating features or in neurodevelopmental features. And in this particular study, which really only looked at 4 school systems across the country, the prevalence was actually much higher than that, about 1.5 to 5%, varying amongst these different school districts. And so we're seeing a rise in the impact of alcohol use in pregnancy, and so I think it bears further underscoring of this message that there has been no safe amount of alcohol that's been defined for use in pregnancy. Various professional bodies have come down more firmly or less firmly. ACOG will say because there is no safe amount, it's recommended to limit use of alcohol, whereas the American Academy of Pediatrics has been much more definitive and said no amount of alcohol is considered safe for use in pregnancy. And so I think we grapple a little bit with how to talk about this, but I think what we're seeing is that in this less explicit place, we're seeing more use of alcohol. And so I think it's calls for some more definitive statement around saying that and I recommend in my clinical work, no alcohol use in pregnancy at all. There are medications for alcohol use disorder, though they are use. It has sort of two components that needs cravings for alcohol use, and then the other is the management of withdrawal symptoms. That phone, which we discussed in the specific mechanism, isn't necessarily applicable. It's much more about the symptom or the feeling of that can drive addiction behaviors that sort of target has shown some efficacy in alcohol use disorder anyway. There are other medications that are used like disulfiram, or also known as antabuse, acamprosate, or Camprol, and topiramate, which is actually an anti-epileptic medication that does have significant benefit around cravings, but there's just not really any data looking at their use in pregnancy. That doesn't necessarily mean that for some person those medications might not be effective, and that the risk-benefit analysis may suggest that you might still want to use a medication like that has efficacy in avoiding alcohol use, but nonetheless, it's important to note they don't have any data for use in pregnancy. Treatment of withdrawal really has not changed at all. We still use benzodiazepine tapers. We recommend through MCPAP for moms, lorazepam most often for the treatment of alcohol withdrawal. It's important just to collaborate with obstetric colleagues depending on the gestational age of the woman, who, in terms of kind of wanting to make sure she has adequate monitoring for her pregnancy and the potential for labor management if needed. But otherwise, that's really not particularly new. One of the substances that we're seeing,
I just wanted to apologize for the you seem to be going in and out. If you might want to.
Thank you.
You're welcome.
I didn't know that. I'm sorry about that. It may just be because I'm using a speakerphone, so I'll move closer to it just to make sure.
Thank you.
Is that better?
Much.
Is it more? Okay, thanks. Sorry about that. So I'm going to shift a little bit to talking about cannabis. So cannabis is one of our most commonly used. In the United States, it's defined as an illicit substance, though in our state, recreational use of cannabis is legal, and so it wouldn't be considered illicit any longer. But the data suggests that despite recommendations to not use cannabis, that women are continuing, 48 to 60% of those who disclosed use prior to pregnancy will continue to use some amount of cannabis during pregnancy. There are no data available suggesting that there are actual medical indications for which cannabis or cannabinoid products have indication, and there are really no great data for the use of any cannabidiol products in pregnancy. So even despite the fact that they're marketed for a number of conditions, there's actually no data for their safety, and there's no data for their efficacy in humans for really any indication other than very, very small, very, very rare conditions such as a form of seizure disorder present in children. It's extremely rare. Called Dravet syndrome. Now, the other piece of data that's particularly helpful to me in thinking about how to counsel my patients when I'm talking about cannabis is that the THC that's in marijuana that's commercially available in dispensaries as well as available privately or on the street, so to speak, is significantly more potent than the marijuana products that were used when some of the original studies demonstrating that there were no differences in outcome either for maternal health or for neonatal health, much of which comes from the 70s. And so what we're seeing people use is really, really quite different and quite significantly more risky. And to that end, a number of medical overseeing bodies have recommended avoiding use of cannabis during pregnancy and lactation entirely. So the U.S. Surgeon General, the FDA, ACOG, meaning the American College of Obstetrics and Gynecology, and the AAP, the American Academy of Pediatrics, all advise women to abstain from cannabis. And this is something that's emerged over the past year to year and a half, are just increasingly data that are suggestive of significant risks. So we do not, and we probably will not have long-term data because it would not be ethical to do studies like this, sort of the gold standard studies for looking at risk. And so it's important to just recognize that we recommend abstaining from all cannabis use during pregnancy and lactation. Just a quick shift to cocaine or methamphetamines and stimulants. One of the things that I'm seeing and hearing clinically in my work in our substance use treatment settings, and that we're hearing anecdotally at MCPAP for Moms, is that methamphetamine use is increasing in Massachusetts, including in pregnant women. And there are relatively few epidemiologic studies very recently, and the most recent data really is about 6 to 10 years old in terms of prevalence, but this trend has been kind of increasing over time. And methamphetamine carries significant risks to health outside of pregnancy as well as within pregnancy, in particular significant risk for agitation, which can cause mechanical injury and risk to pregnancy, psychosis, hypertension, which can confound evaluation of risk for things like preeclampsia. And there really is no pharmacologic treatment for methamphetamine use disorder, and most of the treatment is behavioral contingency management, having the best evidence. But in pregnancy, any methamphetamine use, even if it's not necessarily ongoing use, can carry significant risks to the pregnancy, in particular around the vasoconstriction or clamping down of blood vessels, and that can have really catastrophic risk for pregnancy because it can result in placental abruption. And if it's a large abruption, it can result in both maternal death and fetal loss. There are not a lot of studies on the effects of methamphetamine use in pregnancy, but methamphetamine has been shown to be neurotoxic in animal studies and a variety of different animal studies, meaning it causes cell death in the central nervous system. And also, there has been clear evidence that use of methamphetamine is associated with increased risk for neonatal ICU stay, having some adjustment syndrome that is present either related to intoxication at the time of delivery or some kind of adaptation syndrome related to chronic use throughout pregnancy. And that in a few studies that were examined the childhood outcomes in babies that had been exposed in utero, there's an increased risk for anxiety, depression, and ADHD and other executive function in children who'd been exposed. So this is something that we're seeing more and more of in Massachusetts. It had previously been seen mostly in the West and Midwest and South, increasingly in the Southeast, but now we're seeing it much more in our area too. So just something to be aware of. And this is not to say that it's important to sort of distinguish that methamphetamine use is illicit and very, very risky, whereas stimulants, which are often in the amphetamine category, it's really different. Therapeutic use of stimulants for the treatment of ADHD can be assessed and can be evaluated to be made more safe, or the risks can be mitigated by non-pharmacologic treatment as well. And so it's really important to be able to distinguish therapeutic use of stimulants from misuse of prescription stimulants or misuse of non-prescription medications or non-prescription drugs like methamphetamine. Just a few words about some of the emerging new drugs that are synthetic drugs that are kind of available. Really, very, very little data about their use about what sort of their effects in pregnancy, but I'm hearing about and seeing clinically all of these things being used in young men and women of reproductive age. Synthetic cannabinoids are increasingly available and sometimes easier to obtain or cheaper to obtain than natural cannabinoids, and so examples of these would be K2, spice, bonsai, there's herbal incense it's called. With intoxication, there's been one case report showing that the person using had an eclampsia-like syndrome with elevated blood pressure and seizures. The use of K2 also in very few, limited reports associated with fetal loss as well as neonatal loss early in life, as well as ocular defect and a neonatal abstinence syndrome that's been defined or been observed, kind of an adjustment after exposure during pregnancy. Cathinones are kind of a large category of herbal medications. COT is something that I actually don't see very often, but I've heard people have disclosed that they have found it here and there in Massachusetts. It's often used as either the leaf is chewed or dried and smoked. It has an amphetamine-like structure, and so many of the risks sort of overlay those of methamphetamine, and less seen in the U.S., but still potentially available. Other plant pastes, this is something I'm seeing a lot more of clinically in my work, is kratom, which is a plant-based opioid-like substance. It can be purchased at over-the-counter with often it's in smoke shops or what we used to call head shops, where it's kind of available as a way. Some people will sometimes use it with this idea that it may help them stop using opioids because it does have some activity in the opioid receptor system. It can cause an intoxication syndrome similar to opioids, and also tolerance can develop and then therefore withdrawal. In animal studies, it's associated with neural tube defects. There is no human data right now for embryologic risk, but there is a few case reports demonstrating neonatal withdrawal, neonatal sort of high-toned fussiness that looks very much like opioid withdrawal with kratom use. And then increasingly, I'm hearing and seeing about a lot of non-medical use of psychoactive medications that we prescribe for other indications, so quetiapine, promethazine, dextromethorphan, which is available over-the-counter in cough syrup, and then ketamine. And so each of these really has sort of different effects, and it's kind of hard to describe necessarily, like that most of them are not really associated with significant explicit risk in pregnancy when used as prescribed. Though it's important, actually, that ketamine has been shown to have risk associated with cardiac and neurodevelopmental risk in animal studies, and that in particular with ketamine, that at the time of delivery, in one case report, I think it was a case series rather, there's been sort of a syndrome of neonatal hypotonia and neonatal withdrawal subsequently when ketamine has been one of the exposures during pregnancy. All of these case reports are sort of challenged by confounders and other poly drug use that may have been present in the different mother-infant dyads, and so it's complicated. But mostly what we see when people are using psychoactive medications in a non-medical fashion is really the risk of multiple exposures and the risk of side effects and the risk of sedation alongside intoxication. So just these are trends that we're seeing a lot more in our non-pregnant patients for sure, but also increasingly in pregnant women as well. So MCPAP for Moms is really here to kind of be a way for providers who may be seeing things like this, who may not know what to make of this. We're really here to help. We're here to help address sort of the confluence of maternal mental health and substance use needs. So just as a quick reminder, we have these educational programs. We have our phone line that providers can call at any time. We do some resource and referral services, and then we also have a lot of educational materials. Really, any prescribing provider can call MCPAP for Moms. We're increasingly expanding into the substance use disorder treatment space as well. So hopefully we can really be kind of knitting together this notion of mental health being broad and including what we traditionally considered as mental health diagnoses alongside substance use disorders. We have a ton of educational materials on our website, but most newly we have educational materials focused on perinatal substance use, in particular how to engage in screening and brief intervention for substance use during pregnancy, how to assess what the screening tool I suggested, how to score it, how to assess for severity of illness, overdose prevention, safe prescribing, counseling about the risks of substances in pregnancy. So please take a look on our website for those. Our website, I think, has a wealth of information, both for providers and for patients. And so I want to just sort of thank my colleagues and thank all of you for joining us. And I have some time for questions. I think we have about 10 minutes left for questions.
Yeah, thank you very much, Leena, for an excellent presentation, very comprehensive, and also really interesting to hear about some of the new emerging data that you were talking about, and also trends of what you're seeing clinically and what and so forth. If people have questions, I think we can unmute you, or if you want to add it into the Q&A piece of it. Oh, here's a question. So the question is, does MCPAP for Moms offer any new moms groups for those with a history of a psychiatric illness? And it sounds like this is so for people that are presenting with substance use disorders. Is there also groups for people with a history of psychiatric illness? I think that's the question. Please chat if that's not what you meant.
It's a great question, and it's really challenging to find resources in particular for women who what we would in sort of prior days call dually diagnosed, those that may struggle with mental health and substance use. We at MCPAP for Moms don't actually provide services as much as we're really kind of a service that helps link providers and their patients to services that already exist in the community. And so our resource and referral specialists are really, really helpful in being able to direct towards resources. And there's also a support group finder tool on our website, so you can go on and put in your the town that you live in, and different sort of peer-oriented groups will come up as well. And there's also a fair amount of online resource as well. For women specifically with substance use disorder, there's one resource that I really like to flag or highlight, which is called the Journey Recovery Project. It's a website that has, and the link to our website's on, their website is on our website and in some of the materials as well. But it's really very oriented towards kind of highlighting the patient experience or the lived experience at different places along the journey of pregnancy and into parenting. So I like to recommend that to women who are struggling.
Thank you, Leena. Any other questions? I actually have a question, Leena. So often, you outlined the sort of things that we're seeing around these new different substances that you mentioned, and a lot of them were sort of different versions of things we've seen before, but often it's also a little bit different. I'm curious to hear about some, because these are things we don't have much evidence for, it sounds like. They're new, there's not many studies on it, and not necessarily treatment options. I'm curious to hear how you navigate that when you have women presenting with using substances that aren't sort of, like for example, with opioids, we have pretty clear evidence-based treatment as you outlined. I'm curious to hear with these newer substances that are emerging, to hear about what the recommendations are around that, how you typically handle that clinically.
So I think, I'll sort of approach it different ways. One is trying to understand, like, what are the drivers for use? So, for example, with this kind of increasing trend in use of kratom, or kratom, it's pronounced in different ways depending on who is pronouncing it. But when I've seen it clinically used, there have been a couple scenarios. And one is it can be used primarily for someone who has never used opioids before or used any other substances. But sometimes it's used as a way to stop using opioids or other substances. And if that's the case, then we can have a conversation about what are more evidence-based ways to do that. And other times it's used to address what might be symptoms of another illness, so anxiety, social anxiety, depression, appetite issues, all kinds of things that, cannabinoids are often used to address people use because of nausea-related symptoms, or sometimes just physiologic nausea and vomiting of pregnancy, or sometimes could be other issues, and so or anxiety or things like that. And so it's kind of thinking about, are there other ways to address these reasons that you're utilizing these agents? And then really trying to just kind of engage in as much of the non-pharmacologic approach to use of substances as possible. So we are increasingly seeing the power of peer recovery supports, and there's increasing capacity to an advocacy for being able to bill for those services. And so, really trying to engage with as much support, either peer support through formal recovery coaching, or peer support through 12-step or other programs, engaging in intensive outpatient programs or partial hospitalization programs, short intervals between visits to increase support in the office. And so I kind of think about it from depending on what's the thing that needs to be addressed. Is it a primary use of that substance, which in my experience it rarely is. It's often related to the use of other substances as well. And can we target those?
Thank you. Sorry, I was on mute. Thanks, Leena. That was really helpful. We have another question related. Can the traditional drug screen identify kratom, if I'm pronouncing that correctly?
No, sadly or not, depending on what position you're in about this, no. And I should have been more explicit about that. Of the emerging substances, those new synthetic cannabinoids are not detected by our usual screens for cannabis. Kratom is not, or kratom is not detected by the most typical drug screens, and the plant-based like khat, and even our substances or our medications, our psychoactive medications, there's no way to kind of distinguish between licit, prescribed, and illicit use. So it's really a challenge clinically.
Thank you, Leena. That's helpful.
And that's where it relies on alliance. Just sort of developing an alliance with patients, because often, and in my clinical experience, if you have a good relationship, people will disclose if you can kind of help get aligned around their desire for recovery. And so I'm often surprised by the amount that people will tell me. I mean, it makes me wonder what they're not telling me too, but it actually, even though we don't have a drug test for it, we are able to often find out a lot just by asking and exploring with people. Yeah,
thank you. That makes a lot of sense. Another question, probably our last question, is many of the women this is a question, the person saying, many of the women we screen in our clinic with substance use disorders who are pregnant are prescribed gabapentin by outside prescribers. We're wondering what your thoughts are on this medication in pregnancy. It's a great question. I see this a lot when we get calls.
Yes, and a very astute question, and one we definitely don't have time to really to all the way dig into. I'll say that gabapentin is a complicated topic because it has a lot of benefits. There are a lot of indications. So it can be used for the management of anxiety. It can be used for the management of neuropathic pain. It can be used for sleep. It can be used. Originally was a sort of not a very good one, but an anti-epileptic medication. It is not a particularly good, but often can be used for as an adjunct for mood stabilization. So it has many indications. If the data in pregnancy suggests it doesn't carry explicit sort of distinctive risk, but doesn't appear to be associated with a higher rate of malformations, but there are risks associated with gabapentin, including overdose risk, especially in context of use of other sedating medications or medications that can depress respiratory drive. And its mechanism through the GABA system does create a risk for tolerance and physiologic dependence, and so therefore a potential for withdrawal syndromes as well. So it's not without, while there are lots of indications, it's not without risk. And so often it becomes a question of harm reduction to some extent. So is the use of gabapentin more risky than the use of the substances that the person is in treatment for? can you be achieving some therapeutic benefit alongside decreasing the use of other substances? And so often that's really kind of the way I think about it. It's not always satisfying because it's not a great solution for many things, but sometimes it's a good temporizing measure in the context of sort of early recovery and sobriety, as well as sort of helping kind of with a relatively responsive way to engage around some of the symptoms of discomfort, both around the withdrawal syndrome of whatever they're withdrawing from as well, but also the sort of psychological symptoms that aren't yet adequately treated.
Thank you, Leena. Yeah, that's helpful, very helpful. So we're at time, it's 1:15, so thank you everyone for participating. Any further questions can be emailed to mcpap@beaconhealthoptions.com. Please fill out the survey. Again, we really value your feedback, and please also make suggestions for future topics. And again, the recording will be available on the website. And thank you, Leena, for your presentation and for the Q&A.
And thank you all for having me.
Okay. Thank you. Bye-bye.